Hi, everyone. Good afternoon, or good morning, or evening, depending on which parts of the world you have joined us. I want to specially welcome you to this edition in the series of webinar. And today we are going to be considering a very important topic to pediatric anesthesia, breathing easy from mask to mastery of the pediatric airway. I am Olurotimi, a senior lecturer and pediatric anesthetist from the Obafemi Awolowo University and Teaching Hospital, Ile-Ife, Southwest Nigeria. I'm the co-chair with Dr. Serpil, an associate professor, Department of Anesthesia and Reanimation, uh, and she's the chair of the Pediatric Anesthesia Committee and a council member of the WSFA. We are going to be anchoring the program together today. Let me quickly list or remind us the important guidelines as as we continue our discussion that we can use the chat box for question and answer, which will be attended to at the appropriate quarters at the end of the discussion. Also, this webinar uses AI translation feature for live subtitles. So please, you can select your preferred language in the settings. Also, certificates of participation will be issued within 7 business days of the webinar. And to qualify for the certificate of participation, you are expected to have attended at least 60 minutes of the session. Also, the webinar recording will be published on YouTube within 48 hours. A link will be sent to your email, the registered email. I think this will be the housekeeping rules. So I will want to go ahead and introduce to us our first speaker today. She is Lina Sarmiento. Uh, she's a distinguished medical professional and a professor of pediatric anesthesiology at the Instituto Nacional de Pediatría in Mexico City, where she is responsible for training fellows in the subspecialty. She completed her medical degree and residency in anesthesiology at Pontificia Universidad Javeriana in Bogota, Colombia. Dr. Sarmiento further specialized in pediatric anesthesiology at the Instituto Nacional de Pediatría and holds a Master of Science from Universidad Nacional Autónoma de Mexico. We are glad to have you in our midst, and she'll be taking the first uh, talk. The topic of our talk is PeDI Registry, analyzing intubation outcomes over time. So in the next 15 minutes thereabouts, Dr. Lina Sarmiento, you have the floor. You are welcome. Thank you.
Thank you for your kind introduction. I'm gonna share my slides. Let's see. There we go. You can see my presentation, right?
Yes.
Yes,
Perfect. So, hello everyone, and thank you so much for being here today for this webinar. I'm truly honored by the invitation from the WFSA to be part of this webinar representing Latin America. I am Colombian, but I work in Mexico City. I work at the National Institute of Pediatrics in Mexico City and also at the ABC Cardias Pediatric Heart Center in Mexico City. It's an honor. So today I will be talking about the PeDI Registry. That's the Pediatric Difficult Intubation Registry in light of the latest publication. This work is the result of a team effort and analyzes the registry's outcomes over time, particularly over the last 10 years. I want to disclose that I have no conflicts of interest related to this presentation. So before we jump into discussing the article, let's take a step back for a moment to talk about the PeDI Registry, what it is, and why it's so important. The PeDI Registry is a team effort involving multiple hospitals around the world. It collects data on kids who have difficult tracheal intubations, helping us understand and improve how we manage these cases. So far, 43 hospitals have contributed information on over 8,000 intubations, all done or supervised by pediatric anesthesiologists. It is housed under the Society for Pediatric Anesthesia and gives us valuable insights into what works best for these high-risk patients. Now, what exactly do we mean by difficult tracheal intubation? There are very specific criteria that decide which patients are included in the registry. The first criterion is the one that you see here, is when direct laryngoscopy fails to provide an adequate view of the vocal cords. That means a Cormack-Lehane classification grade 3 or 4. The second criterion is when conventional direct laryngoscopy is physically impossible due to the child's anatomy. For example, as you can see here, here is a child with a cleft lip who has undergone a first stage surgery to mobilize the lower lip flap to the upper lip, which restricts oral opening and makes direct laryngoscopy impossible. So in these cases, it's not about the doctor's skill, it's about actual physical limitations. Third, if the child has a history of a failed intubation within the past 6 months. And fourth, when the anesthesiologist decides that conventional direct laryngoscopy is too risky and proactively chooses an alternative approach from the beginning to prioritize the child's safety, like in this patient with Pierre-Robin sequence. Maybe you can intubate this patient, but maybe if you use the direct laryngoscopy, it's going to be harmful. So maybe the first choice device is going to be the videolaryngoscope. This is a timeline of all the publications from the PeDI Registry to date, starting with the groundbreaking article by Dr. Piaggio published in The Lancet in 2016. He's someone I deeply admire and to whom I'm very grateful for his support. And here at number 14 is the article we'll be discussing in the next few minutes. As you can see, this has been a true team effort, making a real impact on the quality of care for children with difficult airways. All these publications cover a wide range of topics, from basic face mask ventilation to advanced techniques like hybrid intubation approaches. So it's been 10 incredible productive years academically. And if you are an anesthesiologist working with children, I strongly recommend reading these studies. Understanding these findings can make a real difference in your clinical practice. So I'll be presenting this article. This is the article, Airway Management in the Pediatric Difficult Intubation Registry, a propensity score match analysis of outcomes over time. It was led by Dr. Mary Stein and published in eClinical Medicine. This journal is an open access and is part of The Lancet. This article was published online in February of last year. So in this study, we wanted to evaluate whether the guidelines and all the educational efforts to improve airway management in children, especially after the first report from the PeDI Registry in 2016, actually made a difference. Did we change the way we manage pediatric airways? And if so, these changes lead to better outcomes for children? So we compared data from two groups, two cohorts of patients, an early cohort from the initial PeDI registry analysis from 2012 to 2015, and then a current cohort from 2017 to 2023. So we perform propensity score matching. So let's talk about what is that. So before matching, the cohorts show significant difference in ASA physical status, criterion for registry entry, presence of abnormalities on physical examination, anticipated difficulty, and initial clinician managing the airway. So propensity score matching was performed in a 5-to-1 ratio to compare similar groups of patients. The goal was to balance baseline characteristics between the two cohorts. So after matching 5-to-1, the cohorts were similar in all variables with a standardized mean difference of less than 0.1, indicating a good balance between the matched groups. So what were some of the biggest improvements we saw? There are 5 key findings that I would like to highlight. First off, the first attempt success rate for intubation was significantly higher in the current cohort. So that means we were getting the tube in on the first try more often, which is a huge win. That means less trauma, less stress for everyone. Second, there were fewer attempts using direct laryngoscopy in the current cohort, and the persistence with direct laryngoscopy also went down significantly. So it seems like the message about moving away from direct laryngoscopy, if it's not working, it's getting through. And it seems we are realizing that if at first you don't succeed, maybe it's time to try a different technique. We found that more anesthesiologists were using supplemental oxygen during intubation, and they were 3 times more likely to do so in the current cohort. I want to show you this video from my clinical practice. I have fellows in pediatric anesthesiology. Here's Jessica. And what I mean by oxygenation is the use, as you can see here, of a low flow nasal cannula during the intubation attempt. We are also using the video laryngoscope as the device to perform the first intubation attempt. There was a shift in ventilation techniques. We saw a significant increase in the use of controlled ventilation with muscle relaxants to manage these difficult airways. And this suggests a trend towards a more controlled approach to intubation in these challenging cases to optimize conditions for successful first attempt intubation. That's a very concept that we would like to share. Conversely, we observed a decrease in spontaneous ventilation during the intubation attempts, and this reduction might reflect a move away from relying on the patient's own breathing during difficult intubation scenarios due to the risk of airway reactivity, based on the findings of one of the registry studies that we published. And before mentioning the most important outcome, it is important to clarify what we consider severe complications in the registry. These include severe airway trauma, pneumothorax, delayed recognition of esophageal intubation, cardiac arrest, aspiration, the need for a surgical airway, and death. So what we found in this article was that the rate of severe complication was almost cut in half in the current cohort, and we saw a significant decrease in cardiac arrest. So this really shows that these collaborative efforts can pay off big time, and we need to keep doing these good practices. Just to mention, the overall incidence of complications was quite similar between the two groups. There was only a difference here in the severe complications. So what else did the study reveal about how pediatric airway management is changing? One really interesting finding was the rise of the use of video laryngoscope with standard blades, that's Macintosh or Miller blades. It's become a lot more common, and the study found that the use of a standard blade video laryngoscope jumped from just 5% in the early cohort to over 31% in the current cohort, and that's a pretty big increase. We also wanted to figure out what makes a difficult intubation more likely to result in a severe complication. Well, one thing that was a red flag was the presence of airway abnormalities or craniofacial abnormalities. Children with a higher ASA physical status, they were also more likely to have severe complications. And not surprisingly, emergency procedures carried a higher risk. Persistence with direct laryngoscopy, that means more than 2 attempts with direct laryngoscopy, remain significantly associated with severe complications. And this highlights the importance of limiting direct laryngoscopy attempts and transitioning to advanced techniques. Other factors associated were encounters where the anesthesia team didn't induce anesthesia and impossible ventilation. So there is always room for improvement. Where should we be focusing our efforts moving forward? Over the years, education and better access to video laryngoscopy have likely played a big role in improving outcomes. We are seeing progress, and that's great. But despite these improvements, severe complications are still more common in this group compared to general pediatric population. So what can we do? We need to keep working on reducing the use of direct laryngoscopy, making sure patients get supplemental oxygen during intubation, and encouraging a faster shift to more advanced techniques when needed. I think these steps can make a real difference in patient safety. So that brings us to the end of my part of the presentation. Thank you so much to everyone for your attention and for joining this webinar. I hope this overview of the changes in pediatric difficult airway management and outcomes has been informative. Thank you very much.
Thank you very much, Dr. Lina Sarmiento, for your excellent study. And we are thankful for you for your sharing that with us. Now, I want to introduce you Dr. Annery Garcia-Marcinkiewicz. She's an assistant professor in critical care at the Children's Hospital of Philadelphia, University of Pennsylvania. And it's our honor to host her here in our webinar. The floor is yours, Dr. Annery.
Hello and good morning, good day to you, wherever you're joining us from. My name is Annery Garcia-Marcinkiewicz, and I'm an assistant professor of anesthesiology at the Children's Hospital of Philadelphia. Today, I'm going to speak to you about difficult or impossible face mask ventilation in children and lessons learned from that. I have nothing to disclose, but here are some of the affiliations that are very important to me. Let me ask you a question. What if you could see things before they happened? How wonderful would that be? Like in this example.
And everybody fill in, and we're going to ask you to fall, and then they will catch you. So you have to trust us. So I'm going to count to 3. Just relax and fall. Okay? 1, 2, 3. No, wait, no!
I have 3 objectives for you for today. We're going to talk about the incidence of difficult face mask ventilation in children. We'll describe some risk factors that increase the risk of difficult mask ventilation, and we'll formulate plans for management of difficult mask ventilation. This problem right here is one of the greatest airway nightmares that we can imagine. One thing is not to be able to intubate somebody, but now inability to safely mask ventilate is always a terror. It's always a situation that we want to avoid, and better yet, predict before it happens. A lot of work has been done with the Pediatric Difficult Intubation Registry, and I am one that I wish that I could almost rename the registry and look at a subset of patients and call it the Difficult Ventilation Registry, right? Because these are some of the scariest issues that we deal with. So we looked at some of this work, and here's what was found from previous work on difficult face mask ventilation. Overall, the epidemiology was found to be 0.8% in a European study. A Canadian study then looked at this and found that perhaps the incidence of this is 6.6%. We decided to query this in the Pediatric Difficult Intubation Registry. So in those children who are difficult to intubate, the question is, how many of those are difficult or impossible to mask ventilate as well? And what risk factors do these children bring, and what can we learn from that? So this is what the study looked like, and this is the flow of the cases. So at the time, the registry had about 6,000 patients. We were able to have 5,453 cases for analysis. And then we broke these up into easy face mask ventilation, which was the vast majority of the patients, thankfully, and difficult mask ventilation, 429, and impossible mask ventilation, which were 54 patients. And these are some of the characteristics that we found in these patients. Many of them were syndromic. In many cases, spontaneous ventilation was used to mask ventilate these patients. And the overall incidence of difficult mask ventilation was 9%. Regarding the types of syndromes, Pierrot-Band sequence was more frequent, and Treacher-Collins syndrome as well. Other factors that we found here: extremes of weight, less than the 5th percentile, greater than the 95th percentile. When mask induction, as opposed to IV induction, was used, this was actually more protective, associated with a reduced incidence of difficult mask ventilation. And opioid administration was also found to reduce the risk of being a difficult mask ventilation. And we'll talk about this a little bit more. Limited mouth opening was obviously an increased risk for difficult mask ventilation. And here again, you see Treacher-Collins really stands out as one of the syndromes noted to increase this risk. So to summarize these factors, increased risk of difficult mask ventilation was more likely to be seen in infants, extremes of weight, so less than the 5th percentile or greater than the 95th percentile, Treacher-Collins syndrome, glossoptosis, and limited mouth opening. factors associated with reduced risk of difficult mask ventilation, inhalation induction, and use of opioids. And you might say, really, these two factors were protective. Well, this, like I said, will come up again, because here then we enter on the subject of anesthetic depth and how anesthetic depth contributes to helping with mask ventilation in certain circumstances. But what we did note was that when we have patients with difficult or impossible face mask ventilation, their complications are threefold higher. Okay, not surprising, right? These are the patients that are at the greatest risk of cardiac arrest. So very important to do anything that we can to reduce their risk. Look at this patient. This was a patient that I was called to assist with intubation. And this patient had many intubation attempts prior to me meeting the patient. And this is what the patient looked like during every intubation attempt. As you can see, the patient is moving around, arms are flailing. At a certain point, a laryngoscope was placed and the patient became very profoundly bradycardic. This patient has an adequate anesthetic depth, okay? And although, understandably, we don't want to give too much and now lose spontaneous ventilation, we also can't intubate this way either, okay? And these functional obstructive issues sometimes get in our own way and make it difficult, not only to intubate a patient, but also to ventilate a patient. So anesthetic depth is an issue that we need to address, okay? Getting the right intubation conditions, that's at least a third of the job, if not half the job. I always talk about when it comes to airway management, you need to address three main things, okay? The device and technique that you're using to overcome the difficulty of intubation that this patient might have. For example, if the patient has limited mouth opening, you might be doing a nasal fiber optic intubation, okay? If the patient has limited neck mobility, or let's say the patient has an underdeveloped mandible, right? You might want to use a hyperangulated tool, or you might do a trans-LMA fiber optic intubation. So you're choosing a device and a technique based on where the difficulty of that difficult airway lives, right? But then what else do you need to do? You need to provide adequate anesthetic depth throughout the entire airway management encounter. And anesthetic depth for airway management is something that is dynamic, okay? The anesthetic depth that is required to insert a nasopharyngeal airway in the nose is different than the anesthetic depth that is required to place a laryngoscope or to drive and maneuver a fiber optic scope or to pass that fiber optic scope through the vocal cords, okay? Incremental levels of anesthetic depth. And then the third thing you need to do is oxygenate the patient, peri-intubation oxygenation, to buy yourself time. We know that children consume more oxygen, right? And so sometimes we run out of time, and that then turns into another attempt. And then finally, keeping human factors in mind, not doing the same thing over and over and expecting different results, calling for help early, having more people available to assist, right? These are all the things that we want to do during airway management. But let's focus on getting the right intubation conditions, right? Because these data that I just presented is telling us we have an anesthetic depth problem that we need to address. And it's not only creating a situation in which we're dealing with and experiencing difficult intubations as a result of, it's also making face mask ventilation more challenging and sometimes impossible. So why don't we give everybody neuromuscular blockade? Why don't we provide paralytics to every airway? Well, it's not so much because we're worried about mediastinal masses, like you see right here, or tumors in the airway. These are conditions in which we clearly don't want to provide neuromuscular blockade. But thankfully, these situations are less frequent. So it's not this, it's not myalgias, it's not really anaphylaxis. Those are not the reasons why we're necessarily avoiding neuromuscular blockade. Again, because these conditions, thankfully, are pretty infrequent. It's because of this. We're worried about losing the patient's inherent airway tone, okay? And then getting to a point of no return, right? Where if we lose that patient's inherent airway tone, that airway collapses, right? And now we might face a situation where we can't intubate and can't ventilate. So we want to be very careful during these circumstances. Absolutely. So we looked at this a couple of years ago in the PeDI Registry as well. We asked a question: is there a relationship between ventilation technique during initial endotracheal intubation and complications in pediatric difficult airways? At the time in the registry, we had over 1,700 encounters, and we were able to break these up into, first of all, the anticipated difficult airway, so that we can ask the question, how many were managed with spontaneous ventilation, how many with controlled ventilation with muscle relaxant, and controlled ventilation without muscle relaxant. And you can see these numbers here. When it comes to the complications, this is how the complications were defined consistently with every other PeDI registry study. So broken up into non-severe complications versus severe complications. Non-severe complications being things like hypoxemia and laryngospasm, bronchospasm, early recognition of esophageal intubation, versus severe complications being things like severe airway trauma, pneumothorax, delayed recognition of esophageal intubation, cardiac arrest. And this is what we found. Those patients managed with spontaneous ventilation had more complications than those managed with controlled ventilation with muscle relaxant and controlled ventilation without muscle relaxant. And we were like, really? This is not what we expected to find, right? As traditional teaching tells us, you have a difficult airway, manage them with spontaneous ventilation, okay? So that you could always have a bridge to fall back on, right? Keeping the patient breathing the entire time, keeping them oxygenated. In case that intubation doesn't go well, you can just go backward. So we wanted to be really sure. So of course we controlled for several variables that you can see here: age, gender, weight, syndromic status, whether the physical exam was abnormal or not, who was intubating, where that intubation occurred, and what devices were used. And we still found that the odds of having complications with spontaneous ventilation was higher compared to the other two techniques. But we wanted to be really, really sure. So we did propensity score matching, where we matched not only is the airway exam abnormal, yes or no, but exactly where that abnormality lived, right? Where that difference lived. And we controlled for 33 variables that you can see here. So not just can't you open your mouth, yes or no, but do you have micrognathia, macroglossia? Do you have a limited cervical exam? What syndromes you have, etc. And we still found that the odds of having complications were greater with spontaneous ventilation compared to the other two techniques. Why, though? Why is this happening? And this then became the working model. Perhaps when you have spontaneous ventilation, you have reduced anesthetic depth. You're not giving too much, just like that baby that I presented earlier. You're not giving too much medication because you're, again, afraid of crossing the line and burning the bridge, okay? So you're giving very little, but then that leads to increased airway reactivity and these functional obstructive issues that I discussed. And then that is driving the complications. Because you can see here that even though spontaneous ventilation has more complications, controlled with muscle relaxant and controlled without muscle relaxant has really the same lower rate of complications. So it's not exactly the muscle relaxant that is protective. There's something else going on with controlled without muscle relaxant. And that's that we provide greater anesthetic depth with controlled ventilation compared to with spontaneous ventilation, right? And so we were able to actually capture this in the registry and found that spontaneously ventilating patients have increased airway reactivity compared to those that are paralyzed. And patients with increased airway reactivity have a much greater fold of complications. So increased airway reactivity is mediating the relationship between ventilation technique and complications, right? So we have an anesthetic depth problem, Okay, and this is an area of quality improvement. Looked at another way, this study from the PeDI Registry, which looked at sedation versus general anesthesia for tracheal intubation, over 27% of sedation cases needed to be converted to general anesthesia in order to complete the tracheal intubation. So you have to augment the anesthetic depth, right? And turn a sedation, a case initially managed with just some sedation, into full general anesthesia in order to complete the intubation. Again, we have an anesthetic depth problem. So why is it that maintaining an appropriate level of sedation with spontaneous ventilation is so challenging? Well, there's many reasons for that. First of all, sedation is a continuum that can be difficult to establish. Unlike adults, infants and children may be unable to follow directions. We might disagree on what the right amount of sedation is. And very importantly, we don't use this technique, pure sedation for spontaneous ventilation, as often as we use general anesthesia. So we need to get better at it. So when it comes to providing general anesthesia and/or neuromuscular blockade versus spontaneous ventilation, I ask myself these two questions. Is ventilation expected to be difficult? Is access to the oral cavity and/or upper airway blocked by either severely limited mouth opening, tumor, or tissue? And if the answer to these two questions are no, then I'm most likely going to use general anesthesia and/or even provide neuromuscular blockade. Another important thing that we found from that difficult or impossible face mask ventilation study in the PeDI Registry is what happened when neuromuscular blockade was provided. What happened to the quality of mask ventilation after the patient received neuromuscular blockade? And what you can see here is that, generally speaking, it either improved the quality of face mask ventilation or it really didn't change it. In very few instances did it worsen it. And this is suggestive of the fact that you probably have nothing to lose giving neuromuscular blockade when you're now facing this situation of difficult or impossible face mask ventilation, right? So prior to a surgical airway, paralyze, improve your anesthetic depth. Interestingly, one other thing we noticed in this study is that when a provider was in the circumstance of having difficult or impossible face mask ventilation, they reached out for a supraglottic airway less than 35% of the time. Less than 35% of the time. When a supraglottic airway was placed, it generally improved the situation. So why? Why don't we reach out for a supraglottic airway sooner when we're in this situation? We know this. It's in all the difficult airway algorithms. So why does this happen? And this is suggestive of a human factors component, right? When we're in this situation of difficult or impossible face mask ventilation, right? The stakes are really high. We're under a lot of stress. Our cognitive load is increased tremendously. And sometimes we get caught off guard.
Through the window, let me know everything's all right. Summer breeze, go to sleep, go to sleep.
Like in that situation. So don't get caught off guard, okay? You face a difficult or impossible face mask ventilation situation. Remember, a supraglottic airway can help you. So here are some important summary points from this discussion. Anesthetic depth matters. I cannot emphasize that enough. Anesthetic depth, anesthetic depth, anesthetic depth. Please pay attention to that. Neuromuscular blocking agents can improve the quality of face mask ventilation. So please consider those, especially when you're already faced in this situation and things are not improving. You have probably very little to lose at that point before reaching for a surgical airway. And remember your supraglottic airways. They can not only be a rescue, they can also be a bridge to the next safe step. I want to thank you for your time, and please reach out to me if you have any questions or want to discuss further. Thank you very much.
Thank you very much, Annery, for that insightful and very stimulating lecture. Without taking much of our time, we will proceed to the next talk. The topic is awake supraglottic airway placement. And to lead in that discussion is Dr. Mary Lynn Stein. A brief introduction about her. She had her undergraduate, her medical degrees, her combined residency in pediatrics and anesthesiology, all at Stanford University, Atlanta, before she proceeded to Boston for a pediatric anesthesiology training and later an additional training in cardiac anesthesia. Our area of research interest include difficult airway management in pediatric patients, a very relevant topic to a very relevant area to today's discussion, and also perioperative management and risk assessment of patients with pulmonary hypertension. Dr. Mary Lynn Stein, you are welcome. You have the floor. Thank you.
Thank you so much for that kind introduction. I'm just going to share and we'll get started. It's really just such a great honor and privilege to be here today and to be part of this really outstanding panel. And I'll be discussing awake supraglottic airway placement. So we'll start off talking about when I choose it and how I use it. And we'll also talk about the data from the PeDI Registry. So I have no financial disclosures. As a note, when I'm speaking, you may hear me refer to supraglottic airways or SGAs and laryngeal mask airways or LMAs. I use the terms interchangeably in conversation, and I'm not endorsing any particular brand or style of device. I know many of you had questions about the different brands, and we will talk a little bit about the data that's there regarding different devices later on. Oops, getting ahead of myself, sorry. So as we just heard, effective mask ventilation is the bedrock skill of safe airway management and patient care. It's what we teach our trainees from the very first day caring for children, and it's the skill we fall back on when everything else is going wrong. As long as we can mask, we can figure out anything else. But what about those times that we can't mask? Sometimes it's unanticipated, but often an experienced clinician can look at a patient and think, this could be hard. I need to have a plan, and as we just heard, a supraglottic airway is probably part of a good plan. But sometimes you think, this is going to be impossible. Is it too late to switch list? Could I call out sick? And it's those cases when I choose an awake supraglottic airway placement. When by history and physical exam, I have a serious concern that I will not be able to effectively oxygenate and ventilate a child after induction of anesthesia. Often, these are children who have significant obstructive symptoms at baseline. So think of those neonates with Pierre-Robin sequence who are requiring CPAP and prone positioning, or older children with significant acquired or congenital face and neck anomalies. The history is really critical here. Unusual or upright positioning for sleep are real red flags for me. Okay, so we've decided that this child would benefit from awake supraglottic airway placement prior to induction of anesthesia. How do we proceed? As a general rule, I say awake means awake, and asleep means asleep. And in between is often where we run into trouble. Like we were just discussing, anesthetic depth really matters. So if it's a neonate or a young infant, and I want to keep them awake, I keep them awake. I might give a little atropine or glycopyrrolate to dry up secretions, but no systemic sedation. And for this population, I think whether to topicalize is also an individual decision. I find most young infants tolerate insertion without any topicalization. But if you do choose to topicalize, I recommend a small amount of 2% lidocaine jelly or viscous lidocaine on a finger or pacifier. For older children, topicalization is much more helpful and should be approached according to the developmental status and cooperativity of the child. Again, for older children, the decision of whether and how much sedation to administer is very individualized to the particular patient, clinician, and the overall clinical scenario. Some clinicians find that small doses of an anxiolytic, analgesic, or amnestic agent might be helpful, but I caution, remember why you chose an awake technique in the first place, and make sure you don't find yourself in a situation you've been hoping to avoid. Once the patient is prepared, just insert the LMA. I do it just like I normally would in a sleep patient. Open the mouth and then firmly but gently slide the LMA back over the tongue, around the corner, and into the perfect position. Of course, as we said, a question on many of your minds is, which device should I use? There's a really nice network meta-analysis to compare randomized controlled trials of 16 different devices in pediatrics that suggested that the ProSeal may be the best for low risk of failure and high leak pressure. But of course, these studies were not conducted in children we're most concerned about. And your hospital may or may not stock a ProSeal LMA. Mine doesn't. And when we look a little more into the data, we see that several devices have excellent success rates. We can get a good idea of what devices can be successful in these very challenging children that we're talking about by looking at the data from the PeDI Registry. So in the whole PeDI Registry, as you've already heard, there are more than 8,000 cases. And in only 95 of those did clinicians place a supraglottic airway into an awake child. So even in this population of children with really difficult airways, this technique is only used about 1% of the time. As you might expect, most of these cases were performed in neonates, infants, and young children, although there were 16 cases in older children and adolescents. And remarkably, in these extraordinarily challenging cases, the SGA was placed successfully and allowed adequate ventilation 85% of the time. Now, this is a technique that I use if I think I have a really low chance of successfully masking a child. So take those really low odds and bring them up to 85%. Wow. And there were no reported complications associated with SGA placement. So what devices were used successfully in these very challenging children? In the PeDI Registry, we see that not many attempts were actually made with the ProSeal LMA, which was found to be the best device in that network analysis. But the two that were successful. The AirQ was the most frequently used by far, followed by the LMA Unique and the Ambu Aura devices. And we see that while they're usually successful, they aren't always able to provide adequate ventilation. So my honest advice is use the device that you're most familiar with and good at. In my setting, we routinely stock LMA Uniques, and we have AirQ devices for our difficult airway card. So those are the two devices that I use most and I'm best with, and they're what I use. One benefit of the AirQ is that it has a large working channel, which can facilitate intubation through the LMA later on. But remember, the emphasis right now is on successful oxygenation and ventilation. So go with the device that's best for that. Okay, the LMA is in. What's next? First and most important, look at the patient. Are the vitals stable? Are they breathing comfortably? Do you have end-tidal CO2 waveform like in this picture? That nice rectangular, regular waveform? Okay, awesome. Now it's time to induce anesthesia. I usually do an inhalational induction with volatile anesthetic without any additional medications. This allows me to assess the depth of anesthesia and rapidly titrate and reverse course and wake the patient up if things don't proceed smoothly. I'm continually assessing the patient, stable breathing pattern, good end-tidal CO2 throughout the induction. Once I achieve a stable deep plane of anesthesia, I'll then try to deliver positive pressure breaths. Again, assessing good vitals, good chest rise, sustained, unobstructed end-tidal CO2 waveform. Okay, if everything looks good, then we can proceed to our plan for definitive airway management, depending on the clinical needs. But what if everything does not look good? What if instead of a comfortable breathing pattern, you see big retractions, tracheal tugging, and blips of CO2 without a regular tracing? You got to stop right there. Assess what's wrong. This is a child who's in respiratory distress with inadequate ventilation, and we have to improve things right away before it becomes a critical situation. Call for help, quickly assess. Can you manipulate the LMA to improve the seal? Can you perform a jaw thrust or other maneuver to open the airway more? Can you deliver positive pressure ventilation either with the LMA or with a mask? If not, call for help and consider waking this patient up, as the situation could very quickly deteriorate. Okay, but let's say that things have gone well. Patient is asleep. You're able to easily oxygenate and ventilate with the LMA in place. What's next? Well, often we still need to secure the airway. An approach that I really like is flexible intubation through the LMA. We already have an LMA in place, allowing good oxygenation and ventilation. We can keep oxygenating and ventilating through the LMA while we take our time to intubate. In the first image, you see my setup: flexible scope, appropriately sized ET tube, swivel adapter, and of course the LMA. And in the second image, you can see us performing the technique in a real baby, fully monitored, safely anesthetized, with continuous oxygenation and ventilation through the LMA, while we take our time to perform the flexible laryngoscopy and intubation. Okay, so how well does this work? In the cohort in the PeDI Registry we're discussing, so there's 95 patients, all but one of the children were successfully intubated. And remember, these are children with severe upper airway obstruction that we were really concerned about safely inducing general anesthesia. So unsurprisingly, intubation was a challenge with a 35% first attempt success rate. And more than a third of patients required 3 or more attempts. Most intubations were performed with an advanced technique like flexible intubation by the LMA that we just discussed. Okay, so people were able to intubate the children. Was it safe? Remember, remarkably, 85% of cases achieved adequate ventilation with the SGA, and there were no reported complications associated with the SGA placement, and no severe complications in this group. So no cardiac arrest, no delayed recognition of esophageal intubations. We also looked at hypoxia, which we all know can be a harbinger of serious complications. And hypoxia occurred in about 9% of the cases, which is consistent with what we see in the registry. It only occurred in 5% of cases where the LMA allowed adequate ventilation, which demonstrates that by allowing a conduit for oxygenation and ventilation in these children with incredibly challenging airway anatomy, there was actually time for clinicians to successfully manage the airway without compromising patient safety. Of course, when the ventilation was inadequate or impossible through the SGA, those are the really challenging children who are more likely to experience complications, with 36% incidence of hypoxia. But remarkably, even those children did not have any severe complications, and all but one were successfully intubated. So what can we take away from this? The recent European guidelines on airway management in neonates and infants state that awake intubation is largely abandoned in the current era and really reserved for the delivery room resuscitation. But the authors of those guidelines actually said that if this data on awake SGA placement had been available before the guidelines, it would have influenced recommendations. So when you're faced with a child with severe upper airway obstruction and difficult airway anatomy, consider awake SGA placement to allow safe oxygenation and ventilation throughout the induction of anesthesia and airway management. Thank you so much. I'm happy to take questions, and please feel free to reach out by my email, which is on the screen.
Thank you. Thank you, Dr. Mary Stein, for your excellent presentation and studies. Now, we have many questions, and most of them are answered, replied by our speakers, and we have 10 minutes left. So we'll begin with the questions here which are not replied yet. Roger Pivo Sanchez asks, don't you think that using an inhaled induction in a patient with an obstruction can cause anesthetic superficiality and laryngospasm? Wouldn't it be recommended to use an IV induction and early use of relaxants and reconsider TIVA anesthesia in pediatric patients?
Thank you. Yeah, that's a great comment and question. Well, first I want to clarify, it's not that we don't want to have an IV in a patient. Oftentimes I want the IV in the patient who I know is a difficult airway for safety reasons, and I'll happily have that IV and begin with an inhalation induction despite having the IV, because what I'm trying to do is feel the airway and feel the dynamic changes in the as I put this patient more and more to sleep, right? And really, I think what the message is not going from 100 to 0. So the patient is fully awake, and then you go ahead and do an IV induction very quickly, and now you completely lose the airway tone, and now you have the inability to mask ventilate. I think what we're learning from this is, okay, probably, right, an inhalation induction might have been associated with reduced risks because you're going a little slower, and you can always speed up that induction by giving IV agents, okay? And the same thing with opioid. I don't think that the opioid itself is the very protective thing. I think that that is another sign of increased anesthetic depth helps, okay? And certainly if you're in a situation with obstruction, like the scenario that was described in the comment, I do think neuromuscular blockade would be helpful in that regard.
Thank you, Annery. Any other suggestions? Okay, the next one we have, is there any age limits for awake supraglottic laryngeal mask insertion is always or expected difficult situations?
That's such a great question. And it was actually one of the findings from our study that I thought was really interesting and not what I was expecting. So in my own practice, I've predominantly used it in neonates. But actually in the registry, we go all the way up to patients who were 17 who had successful awake supraglottic airway insertion. And those patients did get a little bit of sedation as well as topicalization to tolerate the awake insertion. And there are reports in the adult literature of awake insertion as well. We'll say that a 17-year-old, there's a wide developmental range, but that this technique really can be used in a pediatric psychology and physiology, even in bigger patients. So I wouldn't say that there's any age limit. It's not a technique that I've tried in somebody that I thought was going to be an easy mask or an easy intubation. I've only used it in cases that I thought were difficult, and that was also what was represented in the registry study, mostly out of, well, patients do tolerate it well, concern for comfort, in patients where I didn't think that there was a significant benefit to the technique.
And there are also more questions about wake technique. Do you suggest dexmedetomidine for sedation?
So great question. And actually, if it's okay if I share again, I think I have some of the data on what the different sedatives that were used successfully were. And dexmedetomidine has definitely been used successfully to facilitate what I would call sedated placement rather than truly awake placement. And so I think the screen should be showing again, but you'll see that we divided up the cohort into children who received no sedative medications at all, and then about a quarter received light sedation, which included dexmedetomidine, midazolam at low doses, fentanyl or morphine at low doses, and low doses of ketamine. And then there were just a few patients that were included who received deep sedation. So that would be higher doses of ketamine or propofol less than 2 milligrams per kilo, but had the LMA placed under those circumstances. My own practice, particularly for babies, I say awake is awake. And so I don't give anything else. But for an older child where I really feel like an anxiolytic would be helpful, I think that midazolam or dexmedetomidine can both be used quite nicely.
Thank you, Marie. Regarding LMA, I have a question. Whenever the child has a difficult anatomical airway, it's always, not always, but it's sometimes difficult to put the LMA in it. What's your opinion about this?
Yeah, I would say that the children that I tend to use it in tend to be those Pierre Robin babies with very notable micrognathia. And a jaw thrust, as much as somebody can help with that, can be really helpful in getting the LMA to see kind of around the corner of the tongue. I think the other really great place to use this technique can be in burn contracture patients where a surgical airway is going to be really challenging, and access to mask ventilate and to intubate can also be really challenging. And in those cases, the oral opening can be quite limited. And so I like an LMA that has a deflatable cuff so that you can kind of customize it to the patient's need and make it as low profile as possible. That said, I would still say what you have is what you're going to use the best. And so I wouldn't recommend going out and getting a special LMA that you only use in this very rare circumstance. I think that using what you know and know well is going to be what's most likely to be successful.
Okay, thank you. Any more comments from our speakers? Aaron?
No more comments, and our time is.
I think we can discuss more and more, but we have very limited time. I hope we can continue these webinars and we'll have fruitful discussions later on. Now we have to close, I think. We are very thankful and to our all speakers and to our participants who had contributed a lot with their questions before and after. You know the emails of our speakers. You can reach them anytime, so you can answer. You can ask and get replies. This is an overwhelming webinar and subject to discuss. And also, you know, we have the WCA meeting in Morocco next year. So we invite all of our participants to that gorgeous meeting. And also we will continue our webinars turning in 2 months with journal clubs done by Pediatric Anesthesia Committee of WFSA. So please keep in touch. Thank you, Marie, Annery, and Lina, for your great contribution.
Thank you.
Thank you so much.
Thank you.
Great to know you.